Before we get started, please remember this podcast is for general educational purposes only. We're not providing medical advice, diagnosis, or treatment. Always consult your own healthcare provider about your care. Welcome to Fertility Nurses Unfiltered. 2 nurses, 1 mic, no bullshit.
I'm Ashlee LaRue, fertility nurse and founder of Fertility.
And I'm Laura Wepler, fertility nurse and founder of Navigating Fertility with Laura.
You got questions, the internet has a lot of opinions, but what you really need is 2 fertility nurses who aren't afraid to tell the truth.
No scripts, no sugarcoating, just honest, evidence-based nurse-to-nurse conversation. So let's get into it.
Hey everyone, welcome back to this week's episode of Fertility Nurses Unfiltered. Ashlee and I are super excited to be back with you again this week. And I know we say this every time, but honestly, so excited to have this conversation today. We have Dr. Alecia Fields on, a board-certified OBGYN, to talk a little bit about the gap between OBGYN care and fertility care. Want to hear Dr. Fields' background in OBGYN and becoming a doula and all of the things. So, just to give her a proper introduction, again, our guest today is Dr. Alecia Fields. She's a board-certified OBGYN and FACOG and trained doula through DoulaDoc International. She's also a Gold Humanism and Excellence in Teaching Award recipient, which tells you a lot about the compassionate support for expectant parents and how she practices medicine. And she created DoulaDoc to bridge the gap between clinical expertise, compassion, support for expectant parents, and really helping people feel truly informed, confident, and empowered at every stage of their reproductive journey. Her approach blends evidence-based medicine with real emotional support and real-life advocacy because she believes patients deserve clarity and someone in their corner, not just a rushed appointment. So we're really going to dig in today about what's broken. There's this transition in the fertility space where, patients are seen, by their fertility clinic for weeks and weeks and weeks, and then they get handed off to their OBGYN. And I think they kind of feel like, oh, wow, I went from like this on-hand support, like all the time, and now I'm barely talking to anyone. And so, I'm super excited for this conversation. So welcome, Dr. Fields. And I would love for our listeners, I would love for you to give an introduction to yourself. I'm sure you could do it much more eloquently than I just did. So I would love for you to share like how you got into like OBGYN, like, and going then training to be a doula, like tell us all the things.
Yeah, thanks for having me. I'm really excited to have this conversation too. And my road to medicine was maybe a little untraditional. It was never the thing that I like always dreamed of doing. I actually started in a place of advocacy and working with like community organizations, and then saw medicine as a really great opportunity for advocacy as well. And so I was, a naive but very rosy-eyed undergrad student, just wanting to learn everything that I could about medicine and women's health and reproductive health, and stumbled across a local community business that had doula support and childbirth classes, and that was where I learned about just all the different options that are out there, and really got a different introduction, I think, to the realm of pregnancy and childbirth. And I actually became a doula first. So I was at that point pretty sure I was going to go to medical school, and I had worked with some midwives, and I think OBGYNs sometimes get a little bit of a bad rap. They're seen as like surgeons and a little less on the humanist side in terms of holistic care compared to our midwife colleagues. I think that's improving, fortunately, but I saw that pathway to training and working as a doula as a really nice way to fill in maybe some of those gaps that would be there. And so I had that experience first, which was really interesting then to go through medical school rotations and residency, having that as my first introduction to pregnancy. and birth, and always kind of kept that with me. And then I think it has taken me 5+ years out of residency to be able to figure out how I can really marry those two paths together and combine them into my practice. So,
I think that speaks a lot to what a lot of really wonderful like yourself OBGYNs are faced with, right? It's like, how do you marry and blend why you went into the field, which is helping pregnant women, helping women to get pregnant, helping, just OBGYN concerns in general, depending on your specialty, right? Like you went into women's health for a reason. A lot of OBGYNs went in for a reason. And I think it speaks to sort of part of and I'm sure we'll get more into this, but I think more like the issue that's out there, right? Like you sort of have to blend, like you have a job to do, you have a certain amount of people you have to see, you have to meet insurance requirements. And, there's so much of the business piece because healthcare is a business in the United States that you have to do all those components, but like, how do you then marry the whole like what midwives get a little bit more, like you said, just a little bit more of that like holistic, maybe they have a little bit more time because maybe they're being paid out of pocket or, not within a certain clinic or something. So it's like, how do you marry that as an OBGYN that really does care, because so many of them do, and try and balance that? Like, I want more time with my patients, but I also have to see so many patients because they want my time too. And I think that's part of the struggle is like our system is not set up for OBs to really do what they want to do or have the time that they want to have. And I think that's where a lot of them get that bad rep. If you agree with that.
yeah, absolutely. I mean, I think those realities so many people enter in, just like you said, passionate about women's healthcare, and for a reason, they want to help people. And it's such a really unique and special field. And then you kind of get into the reality of, having to see 30 patients a day and chart, and visits are fast and short, and you're trying to get the boxes checked, and it's easy to get run down and cut some of those things out that are the things that are really important to a lot of us.
It's almost like the system breaks you a little
Oh,
bit.
100%. Yes. I mean, I went to residency after the 80-hour work week. So like, it used to be even worse, but it's like trauma bonding in a way. Like it really did take me like a good 3 years past residency to feel like, oh, I like remember who I am again. And like, I can like actually figure this out and do things the way I got into this for. So it is a system wide issue that even is in the like education system and how we train doctors and how that filters down.
Yeah, for sure. So tell me a little bit then about DoulaDoc and like how that came to be and kind of how you're marrying like your doula side with like being an OBGYN, a trained physician. Like tell me about that experience.
Yeah, so I work in a rural area, and it really came about by seeing some of these gaps that a lot of my patients struggle with. Just they travel a long distance, so their appointments are even more important because they have to travel an hour just for this 15-minute visit, and they don't have as many options about who they can see and where they can go to deliver. And so I was like feeling that frustration of like seeing my patients wanting more and trying to figure out how I could do that. And I also really like education and trying to make enough time for that in visits to talk about everything that's going on in your body and the changes and what's normal, and there's just never enough time. So it started from that space of trying to create a resource for my patients, and it started really on education, different video modules, a pregnancy course. There's so many things out there for labor and birth and how to prepare for that. But it's like pregnancy is 9 months, and there's so much that happens in your body during that time that nobody educates you about. So that was where it started. But then it really grew into, you know, kind of some self reflection about the things that bring me the most joy and the things that I really love doing. And it really are those one on one patient encounters that I have, that I get to know them their whole pregnancy. I get to be there for all those other moments, getting to know their hopes and dreams and struggles and see that whole side of pregnancy. And it's so much more than just a medical event that unfortunately that's what our system has time for, but it is so much beyond that. And we really take that for granted. And so that was where the idea of pregnancy coaching came from, and all the extra support that we could really provide moms and families. And we see the impact that that moms are facing in the postpartum period is a huge gap. And why wait until we get to postpartum where we're just struggling to tread water and stay above? Why not we talk about those things in pregnancy and make sure that those supports are there, and having those conversations so that our patients aren't left feeling on their own.
That
Yeah.
oh
No, go ahead.
I was just gonna say, like, first of all, I think when I was pregnant, which was 9 years ago now, the only resource, and even when patients ask me today for resources, like the only thing that comes to mind is what to expect when you're expecting, right? I feel like that's like the Bible of pregnancy, and there's not
Like
a
the same 80s drawing.
right, right. Um, so I love that you're like bringing more education, like probably more modern education to the forefront through DoulaDoc. But then as you were talking, I'm like, gosh, this resonates so much with why Ashlee and I do what we do in the fertility space, because it really is like that, about that connection with these patients, and caring for them and supporting them through a very vulnerable time, whether that's going through a fertility journey or during your pregnancy. Just like every fertility journey is not linear, every pregnancy journey is not linear, right? We all have different experiences. Some people have symptoms like, nausea and all the things, and some people are like totally fine their entire pregnancy. So I think it's like not a one size fits all. So having you as a resource during pregnancy, I imagine, is very invaluable for the people that you're serving.
Well, and I think it's so true. It's the seeing what's behind face value, just like the clients and patients that you all work with, you know, to one person, it just seems like an overly anxious patient who's seen a bunch of people, a doctor who's busy could look at that and just roll their eyes and not give them that extra time. But really, the backstory of everything that's gone on and everything they've been through, and having that moment to like be compassionate for this other person across the table that's really struggling, and be able to see like so much more is really where care falls short sometimes, but has the potential to be so much better.
Yeah, I mean, I think there's so many people, us included, that are sort of screaming this idea that like healthcare and support is not 9 to 5. It's not Monday through Friday. It's not a 15-minute appointment. It's not, like it is so much. Yes, those things are important. You've got to provide medical care. You've got to do these things. And, there's that has to exist in some capacity. But like, having access to, like, we hear it all the time on our side of like having access to a nurse and being able to text and talk to someone in those moments, the anxiety just, you release your shoulders. You're like, I have someone to reach out to. I have somebody to talk to that's been through it, that has seen it, that can give me like, hey, am I freaking out about this? Should I be calling somebody? Because really what's available after hours are, you go to the emergency room or you call the on-call. And a lot of people don't want to call the on-call. Is this emergency? Is it not? So then we're Dr. Googling and we're asking Reddit and we're asking Chat GPT. And you never know what kind of answers you're going to get or what generic answers you're going to get from that. And so all that to say is that I think we're seeing in the medical field, like we've used to obviously work directly in the clinic, but when we worked in the clinic, we saw this, that it wasn't like after the clinics closed, that's when portal messages flooded in. You get all those voicemails because things happen after hours. So having access to a doctor, a pregnancy coach, a doula, trained doula, all those things combined, as somebody who is pregnant, whether you've been through fertility treatment or not, oh my goodness, that relief, that release of your shoulders, like I can contact somebody who knows what they're talking about, who is a professional, where I don't have to spiral on my own. we just need to like, how do you like bottle that feeling up and then tell everybody like, oh my goodness, how amazing would this be if this was the standard of healthcare?
Yeah. And like knows you as a person. I mean, and sometimes
Yeah.
that's even more than just your medical history. I think that's one of the things we'll talk about later is like, what do you wish providers knew? And it's like, yeah, just knowing that backstory about the patient. It's like they're not a frequent flyer just because they have nothing to do on a Saturday night. Like they're a frequent flyer because they've had a pregnancy loss or they struggled with infertility and they've been through all of these experiences that give them that anxiety where they're always holding their breath and just looking for that reassurance. And like you said, the only place to go is the emergency room.
Yeah. Yeah, or Google. I had a conversation with someone a couple days ago, and she didn't know she had a ruptured ectopic, but didn't realize the pain that she was experiencing was abnormal. She had had a methotrexate shot, which for our listeners who don't know, that's the injection that we give women who have an ectopic to help hopefully resolve before it gets to the point of rupture. But she had no idea that she was rupturing, and she just figured that the pain she was having was normal, and she lost her tube because and ended up with emergency surgery and an abdomen full of blood because she had no idea that and nobody had educated her like, hey, even if you get this shot afterwards, if you have any sort of severe pain, like that's a red flag and you need to go to the emergency room right away. So it just speaks to like, number one, the lack of the way that we educate our patients in the system. I think we all know the medical information. I think sometimes it's very easy to forget to pass on the really pertinent information to our patients. But, this patient certainly didn't feel like she could easily reach out and ask, is this normal? Is this abnormal? And it's heartbreaking.
And it's not just touchy-feely stuff, it's not just the like, oh, we just want to make people have a better experience. I mean, it's really life or death, that
Yeah.
story. And I mean, so many of the maternal mortality and morbidity cases in the country that we see, like so many of them are misunderstanding, systemic racism, things that are providers not seeing patients where they are. And that's a big problem.
Well, and correct me if I'm wrong, is the maternal mortality rate still the highest? Like, is the US still one of like the highest rates of maternal
Yeah.
mortality than most
And a
countries?
country that spends a lot of money on healthcare.
Right. I mean, that's nuts.
Yeah.
I saw there was an article that came out, actually it might have been today or yesterday, speaking of that we're talking about this, of the states that have the highest, and it's very much concentrated a lot in the South where
Mhm.
Dr. Fields and I in Nashville, like it was Kentucky, Tennessee, Alabama, Georgia, Mississippi. It's down in our area, and I think it speaks a lot to like, I think the average for the US is something like 20 something per 29% of, or 20, not 29%. It's like 29 individuals of out of like 100,000, I think was the statistic. Um and in our area it's closer to 50. So it's almost double where we live. And I don't know if that's more rural stuff, if it's people not seeing doctors, if it's hard to like pinpoint what that is. But again, it just speaks to, Laura, like your person's case. We could insert X anywhere. If you had the ability to contact somebody you trusted, that you knew, that you'd already had a relationship with, you, that person specifically in your case, could have gotten help sooner, right? Instead of like, oh, this is normal, this pain's normal, all this kind of stuff. Maybe we could have saved something, maybe not, but like you would have gotten there sooner. And I think there's so many stories that we don't even know about that
Mhm.
can be the case. So I think it's super important what you're doing for so many reasons, but also I think in the location that you are in, just given that we know that down where we live and where we're located it has higher rates. Yeah. So um I want to kind of go back to sort of like, let's go back to kind of the gap we're specifically talking about and or that we want to highlight. And one of those is the discharge from a fertility clinic to seeing the OB. And So for those who are listening, maybe you don't know what that process looks like. So let's say you're at your fertility clinic, and you get a positive pregnancy test. Doesn't matter what treatment, what you went through, you have a positive pregnancy test. For most clinics, they're going to follow you pretty regularly with blood work and transvaginal ultrasound. Every clinic's going to be different, the cadence of this, until about around 8 weeks of pregnancy, give or take. Okay. Some clinics, it's going to be around there. Some clinics, they may push to 9 or 10 weeks. Everyone's going to be different, but very early in that first trimester. And then you'll be discharged to your OB. And your fertility clinic doesn't follow you anymore. And in most aspects, I get this question, I've gotten this question from patients before. Why doesn't the fertility clinic continue to follow, or why can't they continue to follow until at least maybe that first trimester's over? And it's an insurance thing in a lot of cases. The insurance or the fertility clinic only has insurance or coverage through a certain gestational age, which I found was really interesting. And insurance will only have you seen by the doctor so many times throughout your pregnancy, depending on your insurance coverage. So that's a whole nother conversation. But on average, you'll be seen for about pregnancy tests till about 8 weeks. It's about a month time period, about 4 weeks, right? And then you're discharged to your OB. And then every OB, it's going to be different of when they want to see you. Some see you right away. Some wait until closer to 10 to 12 weeks, maybe sometimes even 14 weeks, until you are seen again. And there's no ultrasound or blood work or being checked. And maybe you're weaning off of hormones, right? Maybe you're taking estrogen or progesterone. That tends to be a really scary, what do you mean I have to start stopping my progesterone? The progesterone's what's helping the baby stick at this time. And, we can explain why that's, after an 8-week time period, that's not the case. But that's scary. That is a scary time period of like, okay, I have left these people that I have trusted for months, years, sometimes in a fertility journey with my care of building my family. I am now finally pregnant. Who knows what that history is like, whether it took a long time to get pregnant, whether you've had multiple losses. And now you're being transferred to someone that, okay, maybe you've met once a year for your pap smear. Maybe, you haven't seen as frequently. And then, you go and you see that person and you're not seen as frequently. You haven't built that trust with them. And depending on where you're at, who knows how frequently you'll be seen. And I loved, you did a social media post, and I know I've already shared this with you, but I agree with it. A lot of people are not sharing that they are pregnant during this time period. So it is a very like isolating time of like being excited, being scared, being apprehensive, being, oh my gosh, I'm switching clinics. Like there's so much going on in that first trimester, emotionally, physically. And you called it the invisible trimester for that reason. I'd love for you to speak more to that and more to like what you see on the obese side of those patients coming over and how you try and help and bridge that gap, knowing that you understand this and you do want to help bridge that gap as much. Like, how do you speak to that more?
Yeah, and I think one of the first questions that I kept getting that made me kind of look at this more was like, why don't OB offices see you sooner? Like, why do they wait until 12 weeks? Like, why can't you get me in sooner? And it's a frustration even my clinic has with, for patients saying, why do I have to wait so long? And some of it's logistical, right? Like our schedules get booked to a week or two out, and those first visits are usually longer, so they take a longer slot of time. But some of it is also just the fact that like there's not much we do in the first trimester to intervene. Like the pregnancy is kind of going forward or it's not. And unfortunately, there's not anything that we can do at that point to change that outcome. Now, that's not entirely true, right? Like there's a lot of education, healthy habits, and things like that that we can set ourselves up for success in the first trimester. But I think from a medical standpoint, that's another reason why a lot of clinics don't want to see you in established care until you've got a viable pregnancy. And that sucks. Like just because there is this real risk of loss and uncertainty, that doesn't mean it's any less deserving of support. And if anything, it's probably more worthy of it. But again, some of it is like how many billable visits you get and all of these things that get into insurance, and does it cover an ultrasound, and um, kind of playing politics with people's lives, which stinks. But The biggest thing is, when I get a transfer of care from a fertility office as the OB, usually all I get is like maybe 1 or 2 pages of records, and it's all just about that pregnancy. Like, this was their transfer day, this is their ultrasound, this is their due date, and maybe like a medicine plan if they're weaning off that. But I don't see, how many cycles or the miscarriage that happened before. We might get into some of that in the history, but I don't see the long and sometimes very difficult process that came before they were in my office. All we see is like, okay, you're pregnant. Now let's focus on this pregnancy. So I think that's one thing for patients to know is like we don't see that aspect. And it's not that we don't care, but that's a place that you can also share that with your provider and let them know, because that's certainly a big part of you and big part of your history, but it might not be one of the like formatted questions they ask you when they ask about your past medical histories and your medications, but it's definitely something that's important and goes into your care. um, in terms of it being this invisible trimester, I just also think about that book, the Dr. Seuss book, Oh, the Places You'll Go. And there's that place about like the waiting place. And I just so much think of first trimester as kind of being that like just stuck in this waiting place. Like you can't see anything different, but you might feel horrible. You're waiting for a certain test result or an ultrasound or a week of pregnancy to do something to tell somebody. And when it comes down to it, it's about a third of your pregnancy. Like, so it's not an insignificant amount of time, but it is really this weird waiting place that people find themselves in. And so part of what I was trying to do with focusing on that and talking about it more through DoulaDoc is really giving some people a place to land and things that they can do. Like, there are things that you can focus on in first trimester to take care of yourself, to rest, prioritize healthy habits, and you don't have to feel just stuck waiting. You can do things even in that first trimester, and you can advocate for taking care of yourself in that sometimes hard and period of uncertainty.
Yeah, I mean, and I think the reality, right, when we talk about statistics is that 1 in 4 pregnancies result in a loss, right? And a good majority of those losses, as you said, are, they're out of our control, normally, chromosomal, that, it's just the biology and the genetics, and we can't control whether that pregnancy progresses or continues with any sort of medical intervention, which is, as you said, it either progresses or it doesn't. But I think so many fertility patients or even patients in the general population, because that statistic of 1 in 4 pregnancies results in loss, so many of these pregnancies are happening after a loss. And then that spike of anxiety of like, I need to get past where I was before. And what if this happens again? And as you said, there's no outward signs of pregnancy. I especially see in women who have had losses and then they're pregnant again, but they have no symptoms and they're panicking. Is it, I don't have symptoms. Does that mean something's wrong? And no, it doesn't. You're lucky you don't have symptoms, but symptoms are also the kind of like this weird blessing in a way, because they give you some sort of physical sign that something's happening, and there's fluctuation of symptoms, which then can freak people out. I mean, I remember because I miscarried my first pregnancy around 7 weeks. I didn't find out till 10 weeks. And I remember all through the first trimester with my second child, I was literally like pressing my boobs all the time. I was like, do they still hurt? Like, like, am I still pregnant? Because there was no way to know unless I was able to get an ultrasound or blood work to tell me the levels were still going up. I mean, it's terrifying.
And even I think another just reminder for patients, you know, in the first trimester, there are a few objective data points like ultrasound or blood work, but even those are kind of vague. Like, they don't tell us that much, like there's not, we look at trends for that beta HCG pregnancy number, but it's not like I can get a number and tell you exactly what that means that day. And
Yeah.
so even
Yeah.
the objective data in the first trimester is hard to give you a certainty or an actual answer sometimes. And so that's part of the other reason that we don't do a lot of these tests in the first trimester, because it doesn't always tell us what's going on.
And I think to all of this, right, is like there aren't a ton of interventions or really any interventions in the first trimester, or, that we can do, that we can change sometimes those losses and those outcomes. Um, and that's hard because I think that's sometimes where the distrust in OBs or medical space in general comes from, is because the doctor's supposed to fix it. The doctor's supposed to heal you. The doctor's supposed to help you. And when the answer is there's really nothing we can do in this moment, just because there's not anything we can do, like really there's nothing, that's hard. That's hard on the doctor too. I don't think enough people talk about this. It's like, oh my gosh, like they're rooting for you too. And we've talked about that a lot on the podcast on both sides, but like that's hard a pill to swallow as a patient, because the doctor's supposed, like, I'm going to my fertility doctor for this. I'm going to my OB for this. And you're supposed to, if I'm calling and I'm bleeding or I'm spotting and
Yeah.
like, and then everybody sees on TikTok and everything else of like, oh, I took this supplemental progesterone midway through, blah, blah, blah. And then everybody's like, well, why didn't they give me progesterone? If they would have just given me progesterone, it would have been fine. And it's like, we know that like, that's not real. And that is so hard to explain. And I think that's part of where that gap and that distrust is in the space, because there isn't a lot of things that we can do. But then you see these things online where a lot of people are getting their medical information and their education and that community piece. And that's hard to navigate as a practitioner. And I'm assuming especially as a physician.
Yeah, and I also don't blame patients for turning to those spaces because they're not getting it in the system. We're largely leaving them to fend for themselves. So where else are they going to go other than the internet? And then, yeah, you get a lot of different opinions and ideas out there that might not be evidence-based or helpful.
Yeah, and speaking of spotting, I guess, like I'd love to talk about, like, this is unfortunately early pregnancy symptoms are very similar to PMS symptoms, right? So like while sometimes they can be a blessing, sometimes I think they can be a curse, because I think, the cramping, the spotting, the, breast tenderness, headaches, fatigue, all those kind of things, they can be pregnancy signs. They can also be that your period's coming or some, so it's like, is this good? Is this not? And that's hard to navigate as a patient. It's hard to educate and talk about too, because everybody's going to be different and every pregnancy is going to be different. So that's hard to like overgeneralize that. But I think one of the biggest things that scares a lot of patients, as it should, it is a scary thing, is any type of spotting, bleeding, especially in the first trimester. In pregnancy in general, we can stick to the first trimester. Can you speak a little bit to sort of how you educate on that? How, what sort of reassurance can we give? What would be like proactive steps or reactive steps that like patients can take? Like how if they're calling you up or they're calling their OB, when should they call? What should they be doing in the interim? What kind of information are you going to want to know? And I think sometimes like giving people like, hey, here's, it may be normal and here's the reasons it may be normal and here's the things that could cause it. But then also if X, Y, and Z are happening, here's when you call. Because I think that's a big confusion for a lot of people, is like, is it normal? Can it be normal? And when do I need to call my OB? And is there anything I can be doing in the meantime as I'm sort of navigating this real time?
Yeah, I think that is such a anxiety producing moment. And I think in the end, it's never wrong to call. Like you can always call and ask someone, but I think it's good to not be surprised if the person on the other side of the line says, just watch it. Um, and not feel like they're brushing you off because truly, there's so much extra blood flow to the cervix in early pregnancy, and sometimes it just, intercourse is a huge culprit, but the cervix just changes in pregnancy, and it gets, we call it friable or just a little bit more fragile. And so anytime it gets bumps, sometimes heavy activity, like things like that, even when you go for your pap smear, like it can bleed in pregnancy. And so if it's a small amount of spotting, if it's pink, just, a small amount with wiping, it's not heavy or associated with pain, then that's usually something that it's okay to say, okay, I'm going to watch this and kind of see what happens. And then anytime that the bleeding gets heavy or is associated with pain or dizziness, lightheadedness, then absolutely, even if it's after hours, it's always the right thing to to go see someone at an emergency department. But again, just we don't talk about this kind of hard reality is like at that moment, the reason we want you to go is to make sure that you're safe and healthy, that you're not losing so much blood that it's dangerous for you. But unfortunately, there's not much or anything people can do to intervene for the pregnancy. And so it's really about keeping you safe. And I know so much of pregnancy gets centered around taking care of baby. And that's another thing is like you are a very important piece of this equation. That if there is not a healthy you, then there is not a healthy baby. So, really a lot of the warning signs that we give are really related to making sure that mom is okay and safe and healthy.
That's so important. Especially in the context of, like you said, pain and, abnormally heavy bleeding, like making sure that it isn't something going on like an ectopic, which in the case of, being a patient who was seen in a fertility clinic, at that point you would likely know. But you're right. Like, I think we all see it. Like, I think probably more often than not, I work with patients who experience some sort of bleeding in the first trimester. I think it's probably more rare that people don't have some bleeding. But of course, like it's a cause for panic in their minds anytime
And
that they see.
sometimes, I mean, people unfortunately get stuck where they have bleeding on and off through the whole pregnancy. Like maybe
Yeah.
there was a little subchorionic, like a little bleed by the early placenta. And gosh, that is so stressful to go through first and second trimester, just every once in a while bleeding. And you keep going to the doctor and they're like, oh, baby's fine, nothing to do. And it's like, again, that's that humanism part that, the medical chart says everything is good, check, 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 check. But then you're still left to go home and stress about it every time you go to the bathroom and see pink. So it's
Yeah.
it's that part that the system doesn't always make time for.
Yeah. So going back to that gap a little bit, that, gap between the clinic and the OB, like what are some things that you do in your practice to help like kind of bridge that gap, or what would you like to see better from fertility clinics? It sounds like more of a warm handoff maybe from the clinic provider to the OBGYN. I think, like, what's the practicality of being able to do that at scale, of like calling every OB provider to give, an explanation of the patient? Like, what are some real things that we can do to change this landscape a little bit?
Yeah, I mean, yeah, in my like dream world, we'd have warm handoffs everywhere, but yeah, practicality wise, I don't see that happening. But I think the nice thing about so many fertility clinics is it's such like a collaborative care where a lot of people are working together in a team for a patient. And it's almost like I'd like, not just the numbers part of the medical record, but like a little paragraph summary of like this patient's history and what they've been through and kind of their fertility journey. So you have a little bit of that backstory. But I think I encourage patients to share that with their providers because that's just pieces we don't know otherwise, and we might not think to ask it. But in terms of how we can work together, um, just also trying to remember like what the other side looks like. So not Monday morning quarterbacking anything, and
Yeah.
remembering we're
Yeah.
all like doing this for the same reason and trying to help patients. We just have slightly different practices and setups and goals of care, even and resources. So,
As much as I hate AI, this almost feels like a good use case
mhm.
for, having AI write some sort of discharge summary, taking into account the patient's medical history and maybe trauma that the patients, experience through their fertility journey, and kind of summarizing that
I
for,
mean, that's almost what you need is, you get a discharge summary when you leave the hospital. Like, you almost need like a little discharge summary from the fertility clinic.
yeah.
Yeah, I had a really good point that I was gonna say, and then my mind went blank.
Sorry.
No, you're good.
It doesn't
This
do that to
I
you
feel
all
like
the
this
time.
happens to me at least once an episode. Brain just goes bye-bye. No, I think it speaks to, again, this gap, but it's a little bit of this like narrative that it's like an us versus them sometimes. It's
Yeah.
OB versus fertility doctor and vice versa. And it's like, that's not the case. Like nobody's in the other person's shoes. And yeah, we can overgeneralize and say like, oh, this specialty needs to be doing X, Y, and Z, and oh, this specialty needs to be doing X, Y, and Z. But it's really just like if we just thought about things as simple as that, like a little paragraph at the top could change the experience that you have bringing in a patient. And maybe that does change OB's care. Maybe not yours because you're already bringing people in early, but like maybe if an OB clinic or an OB practice saw X, Y, and Z on that little blurb, maybe it flagged like, hey, this person in certain situations, this person does need to be seen sooner. So we do take into account some of these like historical things that maybe you don't even know from the beginning, right? Like it could, something as simple as that could like change that handoff, could change that care for patients. But I would love to see more of that like narrative changing a little bit. It's more, we talked about it actually when we were talking with an acupuncturist of just like, we were talking about like Eastern versus Western medicine. It's like, what if we worked more together? Like, what if we collaborated more? And just imagine not having that sort of like negative conversation of like handoff here, like hearing your doctor talk negatively about who you're going to next or whatever, like that changes it. We have to remember like that puts that into that our patient's mind instead of like putting a positive spin on things or having that warm handoff or having that trusted resource or experience. That not only changes it for us as professionals, but like imagine the patient just being like, I feel cared for now moving into this next stage, whether that's OB to fertility clinic or fertility clinic back to the OB or whatever the case may be. And again, that's unicorns and rainbows, and I'd love to see it. But like, I mean, I think conversations like this hopefully help to change that narrative and like showing that like both sides really do care. They're working under different conditions, but it doesn't mean anybody cares any less of that experience.
It was making me think of like a utopia in which we have OB providers and REIs working in the same office. And it's just like you're all working together to care for a patient. And maybe like, Dr. Fields, you're the specialist up until the patient has like been trying and not successful. So you pull in your colleague and say, hey, I've been having issues. What do you think? Oh, great. Okay, I'm going to hand off to you. And then vice versa. Like, I don't know, it's like this utopia idea that there's so many reasons going off in my mind why that couldn't work, right? You'd have to like, the patient would have to stay with that OB and that clinic, but I don't know, that would be really cool too.
I mean, we see it in primary care. Like it's kind of that idea of like a patient-centered medical home and like, places where you have all these different specialties that work together. And it unfortunately, I feel like it's just another place where women's healthcare always gets like the least amount of funding and the least amount of attention. But it's like, gosh, like why, I think about this all the time when we head into postpartum. Like, gosh, I wish I had a better warm handoff, for this patient who had horrible high blood pressure and now needs to go back to their primary care. Like
Yeah.
all of this could be so much better integrated to really truly see a patient like from reproductive lifespan throughout their journey. And we haven't figured that out yet. How to do that for
Yeah.
women.
Yeah.
And
Well, and there's so many barriers there with insurance and,
yeah.
For sure.
like,
Yes, reimbursement is different for all those different specialties, and
yeah.
To play devil's advocate a little bit, because I have heard this, right? Like, sort of another gap we haven't talked so much about. Like, we talk a lot about like the pregnancy discharge and going back to your OB, but there's also a gap, I feel like, at the beginning of it, right? Like, you have, an individual or couple that is trying to conceive and coming in and they're seeing their OB. But maybe there's this aspect, and we've seen it too, whether it might not be the OB's fault. There's great OBs, there's not a great OBs. Like we could overgeneralize, but like there's this sort of sometimes delay in
Mhm.
patients getting into fertility treatment for one reason or another. And we could list all those. There's so many of them. But what do you think REIs, but also speaking from your experience, what do you think OBs can do better about maybe having proactively those conversations, or maybe not following the standard, or educating ourselves or yourselves on, like, it doesn't have to be a year in X, Y, and Z scenario kind of thing. You know what I mean? Like, how do we maybe bridge that gap piece that doesn't get talked about enough? And again, it's that us versus them. And like, people can point fingers all day long, but it's like, the reality is, how do we get patients into fertility care sooner so if they do need treatment and care to build their family, they're getting it sooner rather than later, when we know on the female side, time is more of the essence, etc.
Yeah. I mean, I think this is like a huge informed consent process that like you should tell your patients all the options that are out there and let them make that decision for themselves, like from the get-go. And this is something that's interesting because I did residency in a city with a lot of specialists, and that was how I was trained. And so there was an abundance. And then I now live someplace very rural. And it's interesting, like I have a very different mindset than the docs that have been living and working in the trenches of rural medicine for a long time. Like they're so used to keeping everything in house, doing everything themselves. And I get that. Like it is a drive, it is a burden on patients. It is much harder to go to a specialist. But I'm kind of also of the opinion of like that's still their choice. And we should offer that to them. So like any time I have a patient, whatever it is, like whether it's fertility, whether it's prolapse surgery, whether it's it's like, okay, these are the things that I can do, and we can start and try some of these things here, or I can always send you to a specialist. And you could start with me. We could do this for 6 months. We could try it out, and then you could go to a specialist, or I can put the referral in now. Like all of these are options, and and then everybody's different. Like some people are going to say, no, 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 no. I don't want to travel. I don't want to do that. I just want to, stay with you who I know or stay here. And that's great. And somebody else like might want that. And that's okay. I don't think anybody, um, like that's what's best for them. And they're the only people who know that. I don't know what's always best for them. Now, there are some situations, certainly with like patients who are older, if they're coming to me for infertility treatment, that I'm like much more like, you should go see the specialist. Like we should not delay this at all. But for other patients, I think giving them all of those options and that autonomy to pick where they go is really important.
It's interesting because, just speaking from my own experience, like, and I saw a study on this too, and not gonna pretend that I know all the details, or quote it on there, but it was basically a study that looked at like why patients don't proactively bring up if they're trying to conceive or struggling with their OB, and then why OBs maybe don't proactively bring it up in situations. And on the OB side, it's like, it's time. I only have 15 minutes with this person. If they don't proactively bring it up, that's a big conversation. And so that may take up our whole 15 plus minutes when I have other things I need to do. So they're not proactively bringing it up. And then on the patient side, the main answer was, I'm not bringing it up because I figured my OB would bring it up if it was something that needed to be talked about. And I just found that fascinating, because like we're kind of kicking ourselves here a little bit with like, the communication piece of it. And so I can speak from my own experience. Like I have severe endometriosis, and I have decided, because of that and other reasons, I'm childless by choice. And so I've decided not to have kids. So of course I've never brought it up, but I've always just found it really interesting that every single time I've seen an OB, I am almost 40 years old. Nobody has ever asked me, are you planning on having kids? Are you thinking about like, and I just find that really interesting. And again, like it speaks to that small study that I saw. It's probably exactly that. Like I would bring it up if I wanted to have kids, or I was struggling, or I wanted to get off my Mirena or something like that, right? But I just always found it so fascinating that I'm almost 40 years old and my OB has never asked me if I wanted to have kids when I'm reaching the age of potentially biologically not being able to have them. And I think a lot of people are in that boat. And then speaking to that study, it's like that communication gap, not only between OB, RE, like we can speak about that, but like between patient and provider, whether that's RE or a OB. So I think that
Yeah.
like saying that, like my point to that is like, I think there's room for OBs to proactively bring it up if we can, if they can. But I think speaking to our listeners, bring it up to your doctors. They want you to bring it up. And if you bring it up, like, don't, like, if you are experiencing something, you have a question, please ask it. You are not a burden. You are not being too much. You have a right to those answers. And if something is like that, that is your time to ask those questions. And so I would just like put it out there into the universe, whoever listens, to like, please advocate for yourself. If it's not getting brought up, please ask your questions.
Yeah, and I think that's so important because, patients have in their mind like what they're going to the doctor for. And we as providers probably have like a totally, I see annual exam and I'm thinking, okay, how old are they? What are they, what's their pap smear? Do we need STD testing? Are they on birth control? Are we in the age of mammogram? Like I'm going through all these screening things in my head. Do they have a primary care doctor? A lot of patients, female patients do not. Do we need to talk about cholesterol? Like I'm going through all these other checklists, and it might be not at all what the patient cares about. Like they might have a completely different thing in mind that they want to talk about at that annual visit. And so it's not that anybody's necessarily wrong. It's just we kind of have like our blinders on in those moments and have our objectives, and absolutely don't ever feel like you can't bring that up to your provider. It's your
I'm
15 minutes,
so
even if that's all you get.
Yeah.
I'm so curious, like going through medical school and being trained in OBGYN, like what kind of educational piece is there on the fertility side? And like I'm curious also, I guess, with that question, I think there's arguments for and against why we shouldn't do this, but like I mean, to me, it seems like we should be checking AMH as like a marker starting in our mid 20s, and obviously having a discussion with that patient about what the results mean. I think we could certainly draw those results and freak people out for, reasons that we don't need to. It doesn't tell us someone's ability to get pregnant, but it could catch things like premature, ovarian insufficiency, premature menopause.
And even PMOS. I mean, we see.
Yes.
Yeah.
Yeah.
I mean,
which which
um,
is which is important for overall health. I was astounded last week. I went to my primary care physician and I said that I had PMOS. She goes, "What's that?" I was like, "Oh my goodness. Like this
well,
is
I mean, it's
important for
funny
my
that
type 2
you,
diabetes risk." And
yeah, it's funny that you mentioned AMH because like that's not even that new or that old of a test. I mean, when I started residency, and I don't consider myself that old, even though yes, I know that I'm not in the like new doctor phase anymore. Like that was not a test we were talking about. Like it was halfway through residency that they were like, "Oh, here's this AMH test." So it's like nothing that I got in medical school. And so, I mean, doctors who are older than me, like probably aren't even really aware of it. Like it's not even on their radar. And, we have to do, as physicians, you have to do like continuing medical education, but it's really up to the provider to pick what they want that continuing medical education to be in. And so, in terms of OBGYN, it could be on osteoporosis. People could focus on menopause. They could focus on surgery. They could focus on so many different things. So that the likelihood that they're going to focus to stay the most up to date on REI is provider dependent. Um, and in terms of medical school, and we don't get hardly any training in medical school, and in residency, in OBGYN residency, it's a little dependent on where you train, but most people get a rotation or two. So like 1 to 2 months with the REI subspecialty. And so it's not a lot at all. And it's very variable based off of where you are. So not a lot of exposure. It's really kind of then left to like doing fellowship and getting the bulk of that there.
Yeah, we Laura and I talk about this, and we've talked about it with other people too. It's like, oh man, if we could just change like the concept of getting people into treatment, finding things sooner. I mean, we could speak about the delay in endometriosis diagnosis, right? Like there's so many different things. And again, like people like to point fingers and stuff, but if there was just like a fertility workup that we got as a part, like,
standard.
yeah, like you got it every 5 years starting at 25, or I don't know, I'm making things up. But like, if you think about it, like a blood draw, right? Like checking your AMH, maybe checking, maybe baseline hormones if you're around that time of your period, right? Like, and then maybe like a transvaginal ultrasound. Relative, people could opt in and opt out of it, but at least they're like, hey, this is the reason we do it. Here's, what information it gives us. And then at least like just in my brain, it just like, man, we could catch PMS, maybe endo, maybe POI, like some of these things that are very prevalent in the fertility space at a much earlier time than people, because people are trying to have kids later in life. We're trending in that direction. So by the time people get into 30s, mid 30s, depending on where you live, sometimes closer to 40 or so, to try and have kids, at that point, you're like, man, you've had X, Y, and Z diagnosis that you didn't know about because you just never thought about it, or it just didn't affect your daily life, or it just wasn't a part of it and you were focused on other things. So again, there's barriers to that, insurance of course being one of them, and all these kinds of stuff. But like, and again, in our perfect utopia unicorn clinic that we are currently building
I love it.
on this podcast, that would be a part of it.
Yeah, it's like males too. Like, we don't do anything for men, but they're 50% of the equation. And like, they maybe, have no sperm or low sperm count. And how would we know? How would we know? We wouldn't know until.
And then, yeah. And then
Yeah.
for maybe 6 months, the woman's going around thinking like, I'm the problem. It's all me.
Yeah.
And dealing with all the stress and anxiety that goes with that.
Exactly. And then we had this conversation like about a month ago with Dr. Potts, and we talked about like these home semen analysis kits, and like, I mean, there's so much room, I think, for education all around, right? Like education for patients, education for OBGYNs, education for REIs in that transition. Like there's so much room for education. And, I think we've talked about this before on the podcast too, but I think back to like high school and like sex ed class, and like, we don't learn anything about our menstrual cycles. We don't know how they work. Like, I talk to people all the time, like, yeah, I like skip months of my period. Well, there's so many reasons that that's an issue. Number one, you're not ovulating. Number two, your risk of endometrial cancer is increasing. Like, there's just like such a lack of education. And I think so many women and men don't realize what's normal, what's not, and what are the things that they should be thinking about in their reproductive years if they do want children. That's my soapbox.
Yes. Yes. I'm here for it. All of it.
No, I mean, yeah, I think we need more people like us and other people in the space putting out good information, but also helping to talk about these gaps, acknowledge that they exist and they're real, be a voice for patients who maybe don't know how to speak up or want to speak up, and then start to make, hopefully, proactive changes towards it, whether that's in your actual medical practice because you're still working as an OB, but also like what you're creating with DoulaDoc is sort of, you're recognizing that as a physician. And we love having these conversations because we need more people like you in the space trying to make these changes. And it's not a perfect change. We don't have all the answers. We can't change insurance. We can't, but if we're just minutely moving the needle, being louder, talking more about this stuff, creating resources like this, who knows what impact we could make, even if it is for like that next generation of what women's healthcare or fertility healthcare can look like.
Well, and
I think, yeah, go for it.
Oh, I was going to say, it's a lot easier for us to all sit here and point fingers at each other, right? About, well, you should have done this. No, you should have done that, right? But it is a lot harder to, I think, get in a room and collaborate, but that's really what's in the best interest of our patients and, future generations too of doctors and clinicians. Is let's learn how to collaborate and work together and figure out how we can make changes, because the system's not going to fix itself. I mean, the system's just getting more and more broken every day.
Yeah, and I think that it is generational change though too, because I mean that was one of my first peaks and interest in reproductive health care, was like I was a teenager seeing all these people not talking about their bodies and like things
Mhm.
that were happening. And it just was like appalling to me how much shame and stigma there was around periods and sex and, birth control and all these things that nobody was talking about. And it starts in school with education, but it's just the conversations that we have been taught we can and cannot have. And I think so many people just enter into, their reproductive years assuming like it's just going to be fine. I'm just going to get pregnant and I'm just going to go and have this pregnancy and like I'll figure it out as I go and that's just natural. But I mean, getting your period is natural and if you did that with no one preparing you, it's terrifying. Like
Yeah.
don't you want someone explaining these things to you and helping you and figuring out like what pads to buy and not just like leaving you out to figure it out on your own. And these are really huge life changes that yes, you are going to go through and are natural, but you don't have to suffer through them alone. And the system is not built to see that full you as you go through them.
Yeah, I think this is the double-edged sword of social media and us getting more online, right? Is like, we can go back to all of our generations or earlier on. We didn't have online. Like the only information we got was from our moms, from our parents, from other kids at school, from sex ed. Like we didn't have that. So like I think the positive of it is there are more people talking about these topics. There are more people talking about fertility and menstrual cycles and intercourse and all these things, men's infertility. Like I think that's such a positive thing that we're trying to put that, but there is also so much misinformation out there and it is so overwhelming and there are so many people just trying to pry on a very vulnerable population of those navigating fertility, early pregnancy, kind of like we talked about with like the progesterone and things like that when you are early pregnant and like, oh, this worked for me or I did this or when I was bleeding. And gosh, it is that double-edged sword. And I think this is a topic we talk about in every episode too, is like there are so many positives with it that you feel less alone, that like, hey, this happened to somebody else, I'm not on this island by myself. But on the other side of it, it's everyone's trying to sell you something, everyone's
Yes.
telling you do you have to do this, otherwise what are you doing? And so I think again, like having resources like Rooted Fertility Co, like we're doing, like DoulaDoc, like you're doing, it can give people like, hey, sure, I can still have those pieces. And if I still want to be on social media and like have that sort of component, but like clinicians actually that have, helped hundreds, if not thousands of people navigate the specific aspect of the journey, to have that resource to reach out to is I just think like so invaluable. And I think that's a lot of that is like missing in like so many people are turning to that social media and we need to like flip that narrative of like we need to be vetting those resources. So I know we're getting to the top of the hour and gosh, this has just been such an amazing unfiltered conversation about these gaps that has been needed for a long, long time. But would love, Dr. Fields, for you to share kind of where people can find you, work with you, talk more about DoulaDoc, where they can find you on social media, and then sort of end us out with the episode of like what you would like every listener to kind of get from this episode.
Yeah. Okay. So my Instagram is my doula You can find me there. I'm on TikTok as well. And my website is mydouladoc.com. I have information on my social media, education resources that share, but then I also have a couple different programs that you can get involved and engaged with. One is the Pregnancy Companion, and then my new program, which I'm starting, is the Pregnancy Coach, which I'm really excited about. And it's just a chance to work one-on-one and fill in some of these gaps. So I think my biggest takeaway is, just knowing that there are these gaps in the system, and the system is not perfect. And I think where we all are coming from is like we don't want to sit around and wait for the system to get fixed because it's not going to. So just knowing what the limitations of the system are, but knowing that you're not too much for wanting more than what the system can offer. And that is absolutely valid, and that there are so many great resources that are designed to be evidence-based and helpful and not increase your stress load. And it's not a luxury to invest in yourself and prioritize yourself and go out and get the things that you need to get the care that you deserve.
Absolutely. I love that. That was a great piece of advice. I love it. Well, that wraps up this week's episode, but thank you so much again, Dr.
Yes,
Fields, for
thank you.
joining us and
Thank
having
you
this
guys. It was
conversation.
great.
And yeah, we will, for all of our listeners, as we say every week, we'll close out with like, subscribe, DM us, email us, follow us on Instagram, all the places. We will be back next week and we'll see you then.
Bye.
Bye.
If this conversation resonated, like, comment, or subscribe, share, send us your questions. Nothing is off limits.
And wherever you are in your journey, know this: you deserve support that's real and human. Never forget to ask your questions, advocate louder, and remember, you're not crazy. Fertility is hard.
That's it for today's episode of Fertility Nurses Unfiltered. Thanks for spending your time with us today.
We'll see you next time.